Well, hello, everyone. Stragglers, find your seats. We're about ready to begin. So we're recording and we have a virtual audience, so I'm waiting for the thumbs up. Thumbs up. Good evening. I'm Susan L., Vice President and Executive Director of the Foundation for Barnes-Jewish Hospital. Welcome to all of you who are here in person, and thank you for joining us for the first Leading Edge of the year, and welcome to those who are joining us virtually. We have an audience of about 50 folks who are joining us on virtually, so hello there. We're grateful for your commitment to our mission of enriching lives, saving lives, and transforming healthcare through charitable gifts. Now, as a nurse myself, I've been especially eager and interested in tonight's program to hear how the field of nursing continues to evolve and why, to better care for our patients. Our generous donors play such a significant role in that evolution. You are the reason the foundation is able to support both current and future nurses through our hospital partners and also through our Barnes-Jewish College Goldfarb School of Nursing. Let's hear it for the college, right? Your gifts fund nursing research and continuing education and provide life-changing nursing scholarships to bright, dedicated students who go on to care for our community. So thank you. Thank you to all of you who make this possible on behalf of our patients and our healthcare providers. Nurses are at the very heart, someone said I should go like this because I'm wearing a heart pin, are at the very heart of the exceptional care that we provide in the hospital, in our clinics, and in our community. By combining nurses' compassion and skills with today's technology, we're creating a powerful healthcare revolution. Tonight, we are among the first to learn how hospitals across BJC Healthcare are embracing technology to benefit both our patients and nurses through an innovative virtual care model. After the presentation and question and answers that we'll hear from Paula Fessler, who is our Vice President, Patient Care Services and Chief Nursing Officer for Barnes-Jewish Hospital. She will close the program this evening. So let's get started with Tommy Austin, Chief Nursing Executive of BJC Healthcare's East Region. She is BJC's most senior nursing executive and is a fearless, dynamic, visionary leader driving innovation that impacts both our region and the nation. One of Tommy's most important responsibilities is developing and implementing initiatives that improve patient outcomes, standardize our care, and enhance the effectiveness of the clinical workforce. And so now we're going to hear more about that tonight. So please welcome Tommy Austin. Tommy.
Thank you, Susan. And thank you to the Foundation for hosting this important, informative event each year. I'm excited to share our presentation with all of you tonight and to give you a glimpse of how we're changing and improving healthcare for every patient we serve, because everyone deserves extraordinary care. I am so proud to be a nurse at BJC. And when I first arrived, I had all these crazy ideas. We had lots of vacancies in our med-surg nursing, and virtual nursing was one of the initiatives that I had read about and had spoken to other CNOs nationwide that they were innovating about. And so our team rose to the occasion, and I want to celebrate that team of leaders and our project management team, our digital team, who were all involved in making sure that we had virtual nursing for BJC. So will everyone that is involved in this project please stand? Come on, Misty. Can I? Because this was a big cultural shift. And I don't know if y'all had spoken to any of you about the EICU. I was one of the first nurses that initiated the EICU back in the 90s, late 80s, early 90s. And that was such a disruptive technology, right, Lisa? And so you can imagine how disruptive the electronic or virtual nurse is for med-surg nursing. But our goal is to make med-surg nursing what? Hip, cool, and fun. And so remember that, because during the pandemic, a lot of our med-surg nurses flew away from the bedside. And they flew away to the ICU, they flew away to the emergency department, they went to the OR, they went everywhere but med-surg. And so creating an environment whereby med-surg nurses want to be at the bedside was our charge for our organization. And not to mention, we had a large number of agency nurses taking care of our patients. And to provide extraordinary care in this environment, we need to make sure those nurses are BJC nurses. And so that is our goal. And so with that being said, the virtual nurse has become an invaluable extension of the patient care team. The virtual nurse returns time to the bedside nurse to provide direct patient care and gives patients and caregivers seamless access to experienced remote care clinicians and specialists. It also helps our new graduates who are fearful to tell their preceptor, I don't know how to do that. But they can push that button and ask for a consultation and get help from someone in the virtual care center. The virtual inpatient care nurse model integrates with our existing telehealth care delivery system throughout BJC, and Lisa and Radhika will talk more about that. And with the recent merger of BJC and St. Luke's, and it creates us into one strong system, and now we have so many of our hospitals that are the top 3. We are the top 3 in Missouri and 5 of the top 10 in the U.S. News and World Report. So we are growing stronger together. And we've actually spoken to them about their virtual nursing. They've had a virtual nursing for about 3 years. So we're collaborating so that we can deliver the best care that we can. Our hospitals are known for leading the way in ideas and solutions to be the most challenging, to address some of the most challenging issues in healthcare. And we're driven by innovation and a commitment to excellence. And the virtual inpatient nursing model is one example of that. This model also supports nursing recruitment and improves retention to strengthen our nursing workforce so that we can provide extraordinary patient care every single day across our broadened service area. Lisa and Radhika will bring this concept to life for you tonight. I'm so excited to hear about it. Lisa is an experienced critical care nurse and a leader and is the clinical operations director of BJC Telecritical Care, centralized telemetry, and virtual patient observation. And if you haven't had an opportunity to go to the BLI and see that mean operating machine, you need to go look at it. They have screens everywhere, they have people everywhere, and they're making sure our patients are receiving the best critical care services that they can. Lisa has been integral in developing the BJC Telecritical Care program and grew it from a 90-bed pilot program to a high-functioning program that spans 10 hospitals, 14 ICUs, and 325 ICU beds. That is incredible. That is incredible. So thank you, Lisa. That is incredible. So I want to give you a hand. And then Radhika is a dedicated leader, and I'll tell you, when I said virtual, she was on it. She had reviewed the literature, had a PowerPoint, and I asked Misty, I said, who is Radhika? She is on point. So thank you, Radhika. You've been here more than 15 years in acute and critical care, and currently the clinical nurse manager for 2 virtual care programs at the Barnes Jewish Hospital. So I want to give you an applaud too, because you really ran with this program. So through her passion for extraordinary patient care and innovation, Radhika has helped Barnes Jewish become a recognized leader in the fast-growing, evolving area of virtual inpatient care services. Her leadership has increased collaboration through the BJC Healthcare Network to build a virtual inpatient hybrid care model and best-in-class outcomes. It's an exciting time in healthcare, and we're happy you're here tonight to learn more with us. After the presentation, we hope you will take the opportunity to ask questions. So now please welcome Lisa and Radhika, who will shed more light on this next frontier in healthcare. Come on up, y'all.
Bring it down. Hi, good evening, and thank you so much for having us tonight. We're so pleased to present a journey through nursing and ending at a really exciting virtual care nursing program at BJH. We've started this with some groundbreaking time at St. Charles County, Missouri Baptist Sullivan, and now at Barnes Jewish Hospital. I'd like to thank Dr. Tommy Austin for sponsoring us and inspiring us to explore innovative nursing practice across the care continuum, and in doing so, contributing to our promise to provide extraordinary care. Thank you to Amy Hunter, who is unable to be with us tonight, for leading us through the journey, to Julie Lenhart and other members of the Healthcare Innovation Lab for driving an exciting sprint version of proof of concept at BJH, taking us through a really fast-paced program, for our partners in clinical engineering and IS, who are alongside us all along the way, for our nursing leaders at all of the hospitals who have invited their teams to engage in this really interesting way to support nursing care. And as Tommy said, it can be very disruptive for bedside teams. So thank you for engaging your teams and supporting us through the journey. And thank you finally to Radhika Gilmore for her unmatched dedication, as Tommy said, to building an integrated care model alongside us. We're guided by our strategic objectives to achieve patient experience, patient safety, and employee engagement. Okay, it's like clicker, sorry. We're also guided by a successful telecritical care program that was established in 2016, which grew stronger during the pandemic, provided access to patients, providers, and nurses and pop-up ICUs across the system outside of the traditional walls of care. And while we have under 300 ICU patients across the BJC system, Tommy mentioned that we actually provided service to patients, over 300 patients during the pandemic. We were able to get mobile carts and really respond to patient needs and pop-up ICUs. And I call them pop-up ICUs because that's what they were. We used behavioral health floors and maternity divisions and places that were closed. And we were really able to stand up the level of care, scope up nursing teams, scope up physician teams, and provide access to excellent critical care specialists from nursing and physician-based, and really have rode on the coattails of the pandemic, the silver lining of really understanding how to keep higher acuity patients at our smaller hospitals, which helps us enable more capacity at BJH. We're also guided by other health institutions who have embraced virtual nursing and are partners across the state now, and along the care continuum with demonstrated impact in the acute care and not just the ICU patient setting. And we're guided by the fact that while we continue to strategize for the future, we have access to technology today to connect live clinicians to live clinicians. Nursing looked quite a bit different when I started my career at Barnes Hospital in the 1980s. Yes, 40 years ago. Dr. John Lynch was a pulmonary critical fellow. I think he actually came after me. Oddly, jobs were scarce then. Even nursing jobs were scarce. It was like hard to land a job when I graduated in 1983. Even though patient care loads were heavy, and we embraced a team model concept called team nursing. We looked differently, we dressed differently, we documented differently. We started with really long narrative notes, and then we graduated to soap notes, and then we got extremely excited, and we got these huge trifold sheets of paper at the end of the bed, and they were about the size of a bedboard, and we carefully documented our timely vital signs and our IVs and our meds, and we had these little body outlines in which we drew in fluid in the lungs and wounds and drains and all of that. And now we have electronic health records, and we click boxes, and we pull in vital signs, and we have avatars instead of little bodies that we draw on. We mixed and calculated medications differently. We actually mixed our own IV drips. We took it out of vials. I love seeing the nods in the audience. We took it out of vials, we pushed it into our IV solutions. And you know how we labeled them? With magic markers on big wide tape. We slapped it on the bag. We had these burytols that helped us measure more accurate dosing. And we used our wristwatch and drip chambers to time our calculated doses on calculators. Now we have IV pumps that calculate doses. We have pre-mixed meds, and we even have some pump integration that we'll be experiencing and sometime soon at BJH. We monitored and measured heart rhythms differently. Patty Crimmins-Rita, Elaine Thomas-Harton, Nelda Martin's not here tonight. I'm not sure who else did this alongside me. But we had really clunky ECG monitors at the bedside. We had dials that we had to turn up amplitude. We printed strips, and we used these manual little calipers that look like a small version of your geometry teacher's big compass. And we marched through rhythms to time the rhythms and time the intervals. Now we have digital screens, we have e-calipers, and we have auto strips into the electronic health record. Dr. Lynch and I would go to ventilators in the MICU and the RICU, the Medical and Respiratory Intensive Care Unit, and we turned dials on ventilators the size of an old Sears Kenmore washing machine, right? And when we need to apply something called PEEP, or positive end expiratory pressure, you'd get down real low and you'd have to look at the bubble, just like a carpenter's level, in order to apply PEEP and the pressures on the patient. Now we have much smaller ventilators. We have digital buttons and digital pressures, and we have momentary changes for that to understand patients' response to mechanical ventilation. House calls have changed. I'm not actually that old, but it was a great picture. And calls to our house staff have changed. Back then, we would call a sleeping resident, right, who had a 24, if not 36-hour shift, and at the end of their shift, they'd try and sneak a couple hours of sleep. If they were nice doctors, we'd batch calls to them. And if they were smart doctors, they were nice to the nurses, so we'd batch our calls to them. Now we have the ability, as Tommy mentioned, to have a button that is in our critical care units that has an immediate response from a nurse, a physician, an APP on the other side of the camera. We respond we say we need to respond within a minute. We're in there within 10 to 15 seconds. These buttons put an alert in our ear. We have audio, visual, pan, tilt, zoom cameras. The clinician at the other end of the camera has information readily available to them, constantly churned through algorithms to give them up-to-date information. And we have the ability to speak with the bedside team, integrated teams, interdisciplinary teams, and really help them with the trajectory of care, making sound clinical decisions with two-way communication. And we have all of it just in time. We're challenged with a small supply and a high demand for nurses. The rise of the virtual nurse is presented in an AACN 2023 publication. We actually had some of our telecritical care leaders who contributed to some of the chapters on the pandemic and the rise of virtual nursing during that time. AACN is one of the main credentialing bodies of critical care nurses, but it also has released a recent consensus statement in 2022 that talks about the rise of the virtual nurse. Today, there are new innovative models of team care and innovative strategies to respond to the challenges of recruitment and retention and efforts to make acute care hip, cool, and fun again. So the consensus model, sorry, let me back up. I just wanted to read it. The increased disruption to healthcare have highlighted the importance and value of nursing. This innovative specialty area of nursing can provide some solutions to current challenges, including turnover, growing workloads, escalating patient complexity, and an increasingly novice workforce. The nursing profession must focus its attention on research, innovation, collaboration, and change to adequately support patients, communities, and nurses. So even though AACN is a critical care association and credentialing body, they recognize virtual nurse was now a budding way to support innovative care, not just in critical care, but in progressive care units and on acute care units. What goes on there? Today we have the opportunity to leverage our existing technology to carry out our mission of access to extraordinary care for patients, every patient, everywhere, and across the patient care continuum. So whether or not you call us EICU, ERNs, virtual nurses, telehealth, I promise you there is a person on the other side of the camera. We're using tools to help augment care and state-of-the-art technology. In 2016, I had a career change, a nursing career opportunity that Patty Crimmins-Rita invited me to, re-enter Dr. Lynch, Dr. Walt Boyle, and we opened the tele-ICU program together. They asked me to step out of the ordinary, and if you know me, I love to step out of the ordinary. One of my heroes is Miss Frizzle in the Magic School Bus, who tells us to take chances, make mistakes, climb fences, and skin your knees. I'm also driven and intrigued by Major General McCarty, who wrote a book called Team of Teams that talks about military gatherings of teams embedding together to create efficient networks. I love to read. I'm inspired by some of the readings and the leadership opportunities, and listen to Brene Brown and love lessons in chemistry, and inspired by Brie Larson, early women in science, and not being told no, right? So in virtual care programs, we feed our hungry hearts, we fill our open minds, and we remind ourselves daily that the opportunities are endless. But as we gather here tonight, technology requires us to pause and consider dollars and cents. If we want to bring the technology that we've experienced so much success in the tele-ICU program to acute care settings, it totals about $8 million alone for BJH. We are committed to that return on investment through reducing 0 to 1 year nursing turnover, reducing agency spend, and along the way, contributing to job satisfaction, nursing retention, patient experience, improving net promoter scores, and creating a positive impact to our strategic objectives such as throughput and length of stay. This is a slide we love to use to show the integrated care model and how we can stretch along the patient care continuum. Nursing, medicine, virtual care does not have walls. It doesn't have geographic boundaries, and we're really excited to take this more places. And now I would like to introduce Radhika Gilmore, our clinical nurse manager. She's an innovator, she's a fearless leader, and has exceeded my expectations in joining me along this journey in the past year and a half. She's going to take us through the day and the life of a virtual nurse.
Thank you, Lisa. I would also like to take a cue from Tommy and thank the tremendous number of people that have helped us along the way in building this model. I would also be nowhere without my partner in crime, Julie Lenhart, the program manager, that has put all of this multidisciplinary team together to get us started. So I would like to share with you how we have built and developed this virtual nursing model. Oh, sorry, we're gonna go back here. That went really fast. Keeping our virtual inpatient services and our caregivers' needs in mind, we worked with our hospital partners, starting with St. Charles County, thank you, Akene, to create and build this virtual nurse model. We started from square one, each workflow at a time. We really wanted to effectively service our patients and make sure that we were alleviating the workload burden for the nurses at the same time. We kept these 5 strategies in mind as we tested various workflows to understand what added value and what didn't for the bedside care teams. Our workflows are divided into 2 categories. Clinical extensions being the first. The best example of the clinical extension would be how our virtual nurses are mentors. They can, in the moment, be a live person, second set of eyes for that new graduate nurse in the room at the push of a button. This is invaluable for our new hires, for our new graduates. Just as they're entering the workforce, we have been actually doing a sprint at St. Charles County for new hires with this workflow, and the feedback has been wonderful. During the admission process, the virtual nurse helps the patient with intake and ensures a full comprehensive head-to-toe assessment is completed and documented, including a second RN skin assessment. Upon admission, we help to streamline the various questionnaires and coordinate calls with specialists and other care teams. We take the time to provide each patient and family member insights to their stay with the hospital. We also take the time to make sure that we provide all of the background and all of the information we gather to the bedside care teams and to the collaborators such as case managers and social workers. At BJH, at our proof of concept, we have been working with the clinical deterioration models, specifically sepsis, and our assistance in these workflows has helped improve the response time to alerts in cases of possible septicemia. We also support conversational workflows, discharging patients, talking with patients about education, patient and family meetings, talking with bedside RNs about their patients. We are available to answer questions during patient stays, have seen an increase in HCAP scores when it comes to nurse communication, have seen an increase in discharge instruction understanding, just to name a couple. We primarily focus on communication and discharge instructions because we know that these are the best avenues for change to keep our patients at home and living healthy lives. Our nurses have been trained in some specialized education, such as diabetes and stroke education. We're going to continue to add additional specialized training for them. Our proof of concept at BJH, we are providing additional sessions for patients who are at high risk for readmissions. They are getting sessions prior to the day of discharge so that they are getting multiple education sessions before they go home. This has proven to be a staff and patient satisfier. Beginning with admission, we help streamline all of those questionnaires and share information with the other care teams. We can take the time to ask more in-depth questions. We often get more of a picture, a full understanding of what patients' home life is like, what is going on with them socially, and we are able to facilitate earlier planning and needs assessments. So in what little downtime we do have, we audit our patients' charts. We find additional ways to provide support for the bedside care team, and we work with them on small reminders, things that we may have noticed that could be done differently or maybe that we could suggest as an intervention. We also ensure patient documentation is meticulously reviewed for accuracy and completeness. In our first year, we saw 300 interventions for infections that could be an estimated cost avoidance for bloodstream infections and urinary tract infections that would equate to $9 million for 2 of our community hospitals. So we're very proud of this role that we've developed and the outcomes and the enhancements that it's brought to our care teams. So these are some of the comments that our patients had to say. As you can see, patients felt the virtual nurse had more time to spend with them. They felt that the nurses were not rushed. They felt that they were able to ask them all of their questions. Overall, they seemed to enjoy the experience. I've personally worked the desk a few times myself, and it's always fun when someone comes out with a comment like, "I love this new discharge process," or "this new checkout process." What our nurses are saying is they wish it was available when they were graduate nurses. They recognize that the patients enjoy the one-on-one time. When we do admissions and intakes when the patient's still waiting on a bed in the ED, we've been doing some ED holding admissions at St. Charles County. The ED nurses like that it feels like the patients are still moving forward. It also gives the patients that feeling that something's still happening and they're not just sitting waiting, so that patient experience is there. Finally, they love the time that it saves the nurses so that they can spend more time providing that patient care that's hands-on and that they can interact with their patients and they don't feel rushed. A little bit of data. These are some quick numbers. This is some of our progress from St. Charles County and our pilot site at Sullivan. We have an estimated hours returned to the bedside care teams for direct patient care. This is actual time that the bedside nurse has been able to provide hands-on care, such as dressing changes or needed procedures that they have returned back to them because of utilizing the virtual nurse. Admissions and discharge are just 2 of the workflows that the virtual nurses can give that time back to the nurses at the bedside. So we are also finding that the patient education is another time savings for them. But as you can see, every admission and every discharge is an average of 20 minutes back to the bedside, so that they have that time to spend with the patients. Our technology. So we started out very simply. In St. Charles County, we started out with an iPad on a stick with wheels. And we graduated with the more workflows that we developed and the needs that we found were more important and added more value to mobile carts with pan tilt zoom cameras. And we have discovered that to fully scale and to support the valuable workflows of the virtual inpatient nurses, that we need additional technology. We are currently testing our hypothesis that in-room wall-mounted pan tilt zoom cameras are the best solution. We have found that moving and storing the carts are difficult, and flat cameras don't really support those clinical workflows. As we test to ensure in-room cameras are best for our care teams, we have an in-depth user research team conducting contextual interviews and satisfaction research. So here are some of the findings. We early on in the testing saw that connectivity concerns were an issue, and additional carts were already needed. Even when successful coordination happens, it quickly becomes burdensome to the nurses at the bedside to have to go and look for the cart, bring the cart to the room, make sure that they had another cart for the admission that just came in down the hall. So it was becoming an issue for the technology. So about a week and a half ago, we had a celebration at St. Charles County that we have been doing this for a year. We have been in Sullivan since July, and we have been doing this proof of concept at BJH since September. We have seen phenomenal clinical outcomes, RN satisfaction, reduced burnout, and staff retention in our first year. We're thrilled to share this program with you and hope to continue to grow the inpatient virtual nurse in our virtual inpatient services so that we can further enhance care across our continuum and in your communities. We learned from our industry partners and our vendors that very few health systems have such an advanced model. The innovation puts BJH and BJC at the forefront of our industry in how we leverage virtual care to service our patients. This will truly allow us to provide excellence in care in virtual patient care anywhere. So I would like to now open it up to you for questions and tell you more about it.
What is the optimal educational background of the virtual nurse, and what kind of training do you do to prepare them?
So our minimum requirement for the job description, we have put 2 to 5 years experience. We have been very picky interviewing for the position right now because it is pilots and proof of concepts. We have done all of the education ourselves with subject matter experts. So our diabetes education came directly from Carol Recklin at BJH, and our stroke education came from the stroke coordinators. We have been very particular about making sure that we have done everything as appropriate and as cross T's and dotted I's as we can, so that they can be that resource. I was approached by a recruiter asking if we would accept an ADN nurse. And because of the mentor program and being that resource for the new nurses, I was not comfortable in accepting that ADN nurse as a requirement because of the magnet status that we hold and because of being that resource. So we're kind of leveling that off as the bachelor's and that 2 to 5 years. Yes, sir.
Could you tell us something about?
Just for our virtual audience.
Yes. Could you tell us something about the actual interaction between the patient and your and the virtual nurse? Are they obviously there's an iPad that came out, so at some point patients are going to be clicking things. There's some sort of a camera so that obviously patients are going to be communicating with someone. But I guess there are particular potential problems with things like patients who are unsighted or patients who may have language difficulties or patients with problems of say accents and such that you would need special voice recognition technology for.
So we haven't talked about voice recognition technology. We have talked about integrated interpreter services. BJH already has a number of programs in place for that. So we're working on seeing how we can incorporate that into the virtual world. We don't have a lot of answers for that yet. We do have, and we have had virtual admissions or discharges where we have brought in the current interpreter services. We've had the camera and virtual nurse interpreter technology and the patient in the room at the same time, and it's worked, but it's very clunky. So we're trying to find better technology and ways to integrate that. We do have plans and hopes to have closed captioning when and if we can do that as well. We haven't really talked about, I don't have an answer for the voice recognition. That's a new one. Absolutely. Our technology is really advanced as far as us being able to hear them and them being able to hear us. We have the ability to turn up microphones and speakers and all of those things. We haven't run into that yet, but I'm sure it's not far around the corner. So it's definitely something we should add to our list.
I wanted to add that our proposal for pan-tilt Zooms in the room is that which we've been using in tele-ICU for 7 years. It's really quite enhanced technology. We have a great relationship with a trusted vendor due to the size of our program, and we often ask them for enhancements that other institutions do. So we can definitely, field some of these opportunities. I'm looking at Liz, and I'm thinking of haiku and things in Epic that may help us, get past some of these hurdles as well. But great question, and helps us think about opportunities.
So if I can't, to piggyback the last question and expand. So I'm a frequent user of the hospital and probably a pain in the nurse's backside for reference. But when communicating on this device, is this a live person?
Yes.
That's communicating? So we have the accessibility to placate and answer. And then another side of that, and that's great to hear, because all too often we have many, many questions, but there's always then someone within the family that's actually better suited to hear some of these things. And is that accessible? And or what I've found many a time, I go into surgery or something, but the rest of the family needs to be calmed with information. And is this a part of that extension as well? To placate, because I've heard wonderful, our families have always been taking well-informed case, but if it's now becoming on the electronic version aspect, is that being addressed?
So do you mind if I answer this from the
go for it.
EICU perspective? Yeah. So we have the ability in the cameras to have more than one clinician from a remote perspective in the room. We also did a lot of care consultation during the pandemic. We were able to send a secure link to patients and family through an iPhone, and we would monitor that interaction. We even had the ability to provide patient and family visits through this. And so the technology is really outstanding. It is absolutely a live person who has a shift and readily available. Many of our nurses actually rotate to the bedside, so they have a great understanding. Our physicians and EICU all rotate to the bedside. And we're developing some really great partnerships with our hospitalist team at Barnes to really understand how we can really integrate with the hospitalists and understand how we can create that value and that opportunity for care consultation and including the family.
Many of the times it's for the family that needs to be informed. And it's been marvelous as far as addressed.
Good.
And one of the things with the acute care virtual inpatient nurse is that they can schedule a time and let us know that family wants to sit down and ask questions, and we can be available at that time to do that. In addition, like Lisa was saying, it can be as simple as sending you a text message to pull you into that conference call. If we're talking to you and you want your wife to be involved in that call, we can send you that text message and you can be involved in that video call if you're not there at the bedside with him.
Thank you. Very good presentation. I think it was Lisa, did you say you remembered in the early 80s when we had more nurses than we knew what to do with?
I had a hard time finding a job.
Yeah, so it's amazing what 30 years makes, what, more than that. But obviously recruiting nurses is critically important today. And do we monitor and gauge how important this is to a new nurse? Because as I'm listening to this, I was thinking, I think it would be great for certain types of nursing graduates, but others might be a little intimidated by it. And how does that work?
So one of the things that we are doing that I mentioned in the mentor section is we are doing a specific, we call them sprints. Julie taught us how to be very agile and run with our ideas to learn as much as we can and pivot as quickly as we need to change things. We're running a current sprint at St. Charles County Hospitals for new hires for a specific process for the virtual nurses that we call our mentor sprint. So we're gathering input with surveys and data and actually doing a measurement tool on their clinical decision-making process before they start this 6 to 8 week mentorship and post mentorship, so that we can get information on how valuable it is to them or if it's really not a value add. As much as we have gotten back, which has not been a tremendous amount yet, they're having a bunch of new hires start again here in the next month. I'm hoping to gather more, but the qualitative data as far as their comments and the usefulness of how much they find the program has been very positive. Even we had a couple of people that they forgot to tell me how much experience they actually had when they were hired. Well, they're new to the unit. Well, they had 10 years of experience. They don't really qualify. But they went through the program anyway, and they gave great feedback. And even though they did not benefit themselves from the mentorship, they gave us great feedback on the process. And they said it was extremely useful, and they thought that it would benefit new grads, and they thought that it would benefit people that had never worked in that acute care arena before. So we're getting a lot of information. We just don't have as much as we'd like.
We will take one more question, but then we'll have the opportunity to continue the questions and interactions during the reception. Sorry, I looked that up.
Well, thank you both very much. Wonderful presentation and very exciting and innovative work that you're doing, and it's wonderful to hear about it. There is nothing that we do in medicine that is without potential risk or danger. And we know from our experience with technology in medicine and throughout society that there can be adverse effects, that there can be inadvertent consequences that weren't anticipated. So at this early point with virtual nursing, I was wondering if there are any limitations that you would specifically point to, any potential adverse consequences or disadvantages or problems that might arise because of the new technique that would need to be dealt with.
Well, I would say that we haven't encountered any adverse effects. We do our due diligence to understand where it is the most appropriate and where it's safe to support care. For example, we want to try and support the nurses in high-risk med, second documentation. Through these pan-tilt Zooms, I will tell you in the EICU setting, you can see a pupil, you can see a drip rate, you can see the armband, and you can see the med to do that. We haven't ventured in some areas like rules of care or brain death protocols. Number one, that might open itself up to challenges, but number two, when you get into those conversations with patients, we feel like it's important to have somebody at the bedside there with you. So no untoward consequences that I can recall, thank goodness. Some complaints about invasion of their world at the bedside. It's more of engagement and really getting the bedside team to trust us into their world. Nursing and physicians are very protective of the patient and the care. And so really embracing their world, them understanding ours, and working continuously in engagement, I think can help us avoid those obstacles.
Good evening. My name is Paula Fessler. I first want to say thank you very much to Radhika and Lisa. What an amazing program. I know I learned a lot this evening. I'm still learning. I started at BJH about 6 months ago, and as the Vice President of Patient Care Services and Chief Nursing Officer at Barnes-Jewish Hospital. And I actually share with Dr. Lynch and Dr. Austin every time we meet, I still pinch myself. I'm a St. Louis native. I grew up here. I've been gone for 20 years, having last worked at St. Louis Children's as a nurse practitioner. But to come back and to be part of such an amazing organization, I can't even share. It's a daily thought that I review some of the things that we're doing, very cutting edge, really out there to support our teams. What we learned tonight, or what I learned tonight, really reinforces the commitment our organization has to our patients and to their families, knowing that we can connect somebody remotely. If anyone's lived long distance from a family member and they're in the hospital, that's probably the hardest phone call to get, to know that you need to rush back to be able to get that information. So the fact that we can close that loop is pretty incredible. The other piece that I'm most excited about, we have a really wonderful program at BJH, and it's a clinical mentor program where we have a real nurse on site supporting our new grad nurses, and specifically at night and on weekends is when we staff them. It's been a wonderful program, but with the virtual nurse, you're able to do that just in time that you may not get and you may not be able to support as fully. So I'm excited to continue to expand the program our direction, but really a wonderful program. And I'm very grateful to the foundation for hosting this evening, for all of us to have the opportunity to learn. I'm also really grateful for our donors who have made things like this very possible to help support our innovation units at the hospital and throughout BJC. I hope you too enjoyed the presentation, and I look forward to seeing you again at future leading edge presentations presented by the foundation. And then I'd also like you to consider sharing this presentation. It'll be online on the foundation website if you want to share it with your friends and family. And the video will be available on the Facebook page. Lastly, I hope you stay a little bit longer. We have drinks and cocktails and certainly have more time for people to do interactive questions and answers, and I'm sure everyone will be available. So thank you all so much for participating. Good night.